What we're going to be talking about is the identification of fluid collections. Now, I realize that 5 times a day, most of us pick up a dictaphone and say, complete abdominal sonogram, but of course we all realize there's no such thing as a complete abdominal sonogram. Bowel gas is always going to obscure some portions of the abdomen. So then, how does one judge the completeness of a study? And this is particularly important in the area of abscess detection, which will be the focus of this lecture. How is it that we know, and can we know, that the collection or the abscess that we seek isn't sitting behind the one bowel loop that's full of gas in the patient's abdomen? So, much of that analysis, in my opinion, lies in a knowledge of the anatomy of the peritoneal cavity. Peritoneal recesses are an important but often neglected part of our ultrasound anatomy knowledge base. Now, this knowledge isn't neglected because we're lazy. We have rightly become dependent on CT scans to look for abscesses, and we all have a high level of confidence that we will be able to find the abscess with this powerful tool. However, when using sonography, it is important for planning our diagnostic approach to find peritoneal collections, and far more importantly, for judging our level of confidence when the examination is negative. If we're doing a sonogram and we find a big, nasty-looking fluid collection, we're reasonably confident that we found the abscess. But what if it's negative? How confident are we that the abscess isn't there? Well, the first question we have to ask ourselves is sonography as good as CT for finding abscesses? And the answer is no. But I can assure you that with a carefully performed sonogram, the differences are rather small. And if you want to take your CT scanner and your MR scanner, and I'll take my ultrasound scanner, and we'll duke it out, you may beat me, but you won't have a very easy time of it. So when are you going to be reliant on sonography instead of your powerful CT scanner? Well, the patient is too sick to leave the intensive care unit. The patient is too fat to get on your CT scanning table. So in the most critical situation and the technically most challenging situation, you're going to be using the technique that you probably have punted because you have CT. With those introductory comments, let's talk about some of this anatomy. There are many definitions for what is the abdomen, but the simplest definition is everything inside of the transversalis fascia. So how do we find the transversalis fascia? Well, you can start anywhere on the abdominal wall, or I don't care where you start. Start in the thorax, start in the perineum, start in the back, start on the side, start in the front. Once you dig through the muscles, you find the transversalis fascia. Then there is some fat, the properitoneal fat, and then, of course, the parietal peritoneum. So again, start anywhere on the abdomen. If you want to find the transversalis fascia, you find it between the muscles you dig through and the parietal peritoneum. Within the abdomen, as you're well aware, 2 large spaces, the peritoneal cavity, which is, of course, the largest potential space in the human body, and the retroperitoneum. We usually think of the peritoneal cavity as empty, which is generally appropriate, but in fact, it usually contains about 25 cc's of fluid, which circulates about once every 24 hours. So the peritoneal cavity, as you know, is the space between the visceral and the parietal peritoneum. So if we identify our parietal peritoneum and our visceral peritoneum, then the gaps in between are the peritoneal cavity, nicely drawn here for us by Dr. Netter, but as you realize, the gaps don't really exist. Those are simply potential space. The retroperitoneum is the space between the transversalis fascia and the posterior parietal peritoneum. So here we chose to dig through the back muscles. As soon as we got through them, we ran into our Transversalis fascia, if we wanted to stand in the pleural cavity, dig through the diaphragm, we'd find the transversalis fascia. Go from the other direction, find our posterior parietal peritoneum, and there we identify the organs and some of the fascia we typically associate with the retroperitoneum. All seen better in axial planes, where here we're digging through the very thick back muscles, but as soon as we get through them, we run into our transversalis fascia, posterior parietal peritoneum, and all of the organs we typically associate with the retroperitoneum. Now, the one thing I would like to point out is that the psoas muscle is a body wall muscle. A psoas abscess is a body wall abscess. It is not a retroperitoneal abscess. This is often mistaken for two reasons. Number one, we're all taught in medical school about the psoas sign in people with retroperitoneal abscess. That's because a retroperitoneal abscess can irritate the psoas muscle. And the other reason is that abscesses want to do one of two things. They either want to find their way to the surface of the body so they can rupture out, or they want to kill you, one or the other. And you can see here that it's going to be very difficult for a psoas muscle abscess to find its way to the surface of the body. So when it ruptures, it typically ruptures into the retroperitoneum, where it then becomes a true retroperitoneal abscess. Because of the time constraints, we're just going to talk about the peritoneal cavity, and the anatomy we will be talking about is anatomy that was sorted out by a physician named Morton Myers. The older members of our audience will all know who Morton Myers was. The younger members may have never heard of Morton Myers. But he sorted out all this anatomy before there were ultrasound scanners or CT scanners. He took cadavers and injected radiographic contrast agents into their peritoneal cavities, rolled them all over the place, and then radiographed them and sorted out this anatomy. Pretty amazing, if you ask me. Now, this is a pretty scary picture with all these labels on it, but in fact, when you break the anatomy down, it's reasonably straightforward. And the key structure is the transverse mesocolon, which divides our peritoneal cavity. So in this picture, we can see the liver has been resected, the stomach and some of the duodenum has been resected, the small bowel and the colon have been resected. Now, if we look at the back of the liver, I just want to point out to you, obviously they had to cut the coronary and triangular ligaments to remove the liver, among other things. But I want to point out that the liver is suspended from the dorsal body wall. It is not suspended from the cupola of the hemidiaphragm. As we said, the dividing line of the peritoneal cavity is the transverse mesocolon. It divides the liver into the supramesocolic spaces, those are the ones that are above the line, and the inframesocolic spaces, those are the ones that are below the line. So, if we identify our transverse mesocolon, we see that it runs from the pancreas to the transverse mesocolon, to the transverse colon. So these gaps are the supramesocolic spaces, and all of these gaps are the inframesocolic spaces. We're going to start with the supramesocolic spaces. There are 6. 3 on the right and 3 on the left. They are divided right from left by the falciform ligament. Now, the falciform ligament, as you realize, is something that we see consistently on both sonograms and CT scans, particularly if there is ascites. We can see the falciform ligament quite beautifully. And it divides the supramesocolic spaces into the right-sided and left-sided spaces. The spaces are analogous, so we have a right subphrenic space and a left subphrenic space. Unfortunately, the subphrenic spaces are erroneously often thought of as being immediately under the cupola of the hemidiaphragms and reasonably small spaces. Nothing could be farther from the truth. These are very capacious spaces. In fact, they are the largest of the supramesocolic spaces, and it wouldn't be impossible at all for somebody to have 3 separate abscesses, all of which needed to be drained, all of which were in the left subphrenic space. So the right subphrenic space, of course, is divided by the falciform ligament. It starts cranially at the coronary and triangular ligaments, covers the entirety of the medial segment of the left lobe and the entire right lobe until you run out of liver going caudally. The left subphrenic space starts again at the coronary and triangular ligaments. In the cephalad location, cover the entirety of the lateral segment of the left lobe of the liver, the entirety of the stomach, and the entirety of the spleen. Now, importantly, air in the stomach cannot stop the beam from interrogating the left subphrenic space, but you have to know where to place the transducer. If you place the transducer here, the beam must pass through the left subphrenic space before it can be blocked by air in the stomach. As I said, these spaces are very large, and you can appreciate the tremendous volumes of fluid can be housed within the right and left subphrenic spaces. Indeed, the left subphrenic space occasionally will disproportionately show very large accumulations of fluid, and I'll come back to that a little bit later in the lecture to say why that happens from time to time. Now, here we're dealing with a left subphrenic abscess. You find left subphrenic abscesses superior and lateral to the spleen, so we identify the spleen. We see that that is posterior and lateral to the spleen, left subphrenic abscess. Of course, you can have a subphrenic abscess that is under the cupola of the hemidiaphragm. And on the left side of the abdomen, potentially that might want to hide from you. But generally speaking, if you have an abscess under the cupola of the hemidiaphragm, it stimulates a pleural effusion. So you will have a beautiful window through which you can examine virtually the entirety of the cupola of the hemidiaphragm, identifying this gas-containing abscess underneath. The next space in the supramusicolic region is the right anterior subhepatic space. It's analogous space on the left side as the left subhepatic space, but we seldom call it the left subhepatic space. More often we call this the gastrohepatic recess. Why? Because it lies between the lateral segment of the left lobe of the liver and the stomach predominantly. That's not the exclusive extent of that. But we can get a feel for the right anterior subhepatic space and the left subhepatic space better in the frontal projection by retracting the liver. And we can see that the gastrohepatic recess lies between the lateral segment, the esophagus, the stomach, and the gastrohepatic ligament, whereas the right anterior subhepatic space lies predominantly between the gallbladder and the duodenum. So in an axial plane, you see the position of the left subhepatic space between the liver and the stomach, and the right anterior subhepatic space lying between the gallbladder and the duodenum. The next space on the right-hand side is the right posterior subhepatic space, much better known as the Morrison pouch. And we can see the anterior subhepatic space between the gallbladder and the duodenum, and the posterior subhepatic space between the right lobe of the liver and the right kidney. Now, this patient doesn't have a gallbladder. The gallbladder has been excised, but we do see the duodenum nicely filled with fluid. We have our anterior subhepatic space on the right side and our posterior subhepatic space between the liver and the right kidney. Now, although fluid can freely flow between these spaces, they don't necessarily communicate in the way we ordinarily think of things communicating via gravity. If gravity was the reason that fluid accumulated, then this fluid in the anterior subhepatic space would have flowed down to join this fluid in the posterior subhepatic space, but it didn't, frequently doesn't, and that is because it isn't gravity which is determining fluid locating in these locations. Now, If ascites can do that, then an abscess, which immediately the body begins to wall off, will very often locate in one or the other of these peritoneal recesses. When there are large amounts of fluid, then these do tend to run together, and we see the right anterior subhepatic space between the gallbladder and the duodenum, the right posterior subhepatic space between the liver and the right kidney, and the right subphrenic space overlying the right lobe of the liver. Now, importantly, bowel gas cannot stop the beam from interrogating the right anterior subhepatic space. If you place the transducer in the right location, the beam must pass through the anterior subhepatic space on the right side before it could possibly encounter gas in the duodenum. So, immediately upon exiting the posterior wall of the gallbladder, the beam necessarily immediately enters the right anterior subhepatic space before it could even possibly encounter the wall of the duodenum, let alone gas in the duodenal lumen. Now, I will make this point many times. Volume is not the issue. You take your CT scanner, your MR scanner, your nuclear medicine scanner, your fluoroscope, anything you want. I'll take my ultrasound machine, and we'll see who can find the smallest amount of fluid, and by noon, you'll cry uncle. Okay? Ultrasound is the greatest tool ever made to find fluid. So here we see small amounts of fluid in the right subphrenic space and the Morrison pouch. Here's the bare area of the liver. This is less than 2 cc's of fluid in the right posterior subhepatic space. It's abundantly obvious on that sonogram. Now, we're talking a lot about the transverse mesocolon, but in fact, nobody looks at a CT scan when it says rule out abscess and goes looking for the transverse mesocolon. And I don't look at a sonogram and say, oh, where's the transverse mesocolon? It just happens to be the dividing line of the peritoneal cavity and does present somewhat of a barrier. So here's the transverse colon, we see the transverse mesocolon, and we can see that it does indeed provide a barrier. Fluid in the subphrenic space, fluid in the anterior subhepatic space. Importantly again, gas in the duodenum, of which there is plenty in this patient, cannot stop me from finding this abscess in the right anterior subhepatic space. The beam must pass through that before it can encounter gas in the duodenum. So, it's not an issue of big abscess and small abscess in terms of detection. It's a matter of interrogating the space. So, these small abscesses would not be drained by an interventional radiologist. They're too small to go after. So if we're going to have our contest be, we're only going to look for abscesses that actually end up getting drained, you're going to have a really hard time beating me. You'll probably beat me, but you won't. You'll sweat it out before you beat me. So, again, the supramesocolic space is on the right side. In this patient, we have the anterior subhepatic space and the posterior subhepatic space with a moderate amount of fluid, but only a small amount of fluid in the right subphrenic space. Here, there's a lot of fluid in the right subphrenic space, small amount in the anterior subhepatic space, and just barely a drizzle down there in the posterior subhepatic space. So, on the right side of the abdomen, have I seen the subphrenic space? The answer is yes, if I've seen the right lobe of the liver. Have I seen the anterior subhepatic space? The answer is yes, if I have seen the gallbladder. Have I seen the posterior subhepatic space? The answer is yes, if I've seen the right kidney. How often do I see those? All the time. Now, you can appreciate that this subphrenic abscess can't be missed if you actually examine the right lobe of the liver. Now, I'm not trying to denigrate the anatomist that drew this picture for this surgical textbook, but let's face it, They drew the liver suspended from the cupola of the hemidiaphragm. It's not. And this surgeon's going to have a heck of a time here because his finger's on the wrong side of the transversalis fascia. Now, what's my point? My point isn't to make fun. My point is the surgeon's trying to drain an abscess. He doesn't really give a damn about the transversalis fascia and the cupola of the hemidiaphragm. He's interested in the abscess. Same thing with an interventional radiologist. Same thing with you looking at a CT scan. You're not really interested in all that other stuff. You're interested in finding the abscess. Now, what I want to point out is that the liver is soft and abscesses are hard. Now, we all know and love the claw sign. But the claw sign doesn't work around the liver with abscesses because this is a subphrenic abscess, and you'll see the claw sign. So the liver is hard, the liver is soft, abscesses are hard. It can be very difficult to decide what's in the liver and what's out of the liver when it comes to abscesses in the perihepatic region. Oh, and by the way, that's the one thing on this drawing that I agree with. The artist drew it with a claw sign. Here, the artist also drew this abscess in the Morrison pouch with a claw sign. I agree with that too. So you can appreciate that you couldn't possibly examine the right kidney and not find that abscess. The gastrohepatic recess, as we said, predominantly lies between the lateral segment and the stomach. So if we can see the stomach, we know that the beam has passed through the left subhepatic space or gastrohepatic recess. In fact, in order to see air in the stomach, the beam must have passed through the gastrohepatic recess. So as soon as I see that air in the stomach, I know that the beam has already been through the gastrohepatic recess. So I've interrogated it, it's empty. So to reiterate, gas in the stomach cannot stop me from seeing the gastrohepatic recess or the left subphrenic space, and gas in the duodenum cannot stop me from interrogating the right anterior subhepatic space. Now, it sometimes bothers people that you find the lateral segment of the left lobe of the liver in the right upper quadrant, and how does that work? Well, the reason it works is because the lateral segment of the left lobe of the liver and the stomach are together no matter where you find them. The only thing that ever causes the lateral segment and the stomach to not be touching one another is pathology. Something had to separate them for them to move apart. So I don't really care where I find the lateral segment. If I found it, I found the gastrohepatic recess. Now, in this patient, we're fortunate enough to have a nasogastric tube in the stomach casting that shadow, so we have a very precise localization of the stomach, and you can appreciate that as soon as the beam exited the lateral segment, it had to find this blood in the gastrohepatic recess in this person with a hemoperitoneum. Now, again, I want to reiterate, volume is not the issue. The issue is beam direction. So if we place our transducer properly, we are going to find that 1 or 2 cc's of fluid in the gastrohepatic recess. We can't miss it. So again, abscesses in these locations are not difficult to detect. Here in the right anterior subhepatic space, you can see that immediately upon exiting the gallbladder wall, the beam had to go into this abscess. The abscess is going to push the bowel out of the way. It doesn't care whether it has gas in it or not. It will push it out of the way. This patient perforated his gallbladder, has lots of bowel gas, but that bowel gas can't stop me from finding this abscess in the anterior subhepatic space. Similarly here, I don't care how much gas is in this bowel, the abscess in the gastrohepatic recess pushes the bowel away from the lateral segment. Immediately upon exiting the lateral segment, the beam enters the gastrohepatic recess. So bowel gas is not going to stop me from finding abscesses in the gastrohepatic recess. That one's getting some pus sucked out of it. Now, the analogous space to the Morrison pouch on the left side is the lesser sac, or more appropriately, the lesser peritoneal cavity. As you know, The lesser and greater peritoneal cavities are separated by the lesser and greater omentum. But here we're only interested in the lesser omentum. The greater omentum, or the omental bursa, is fused, so we don't get fluid collections in the omental bursa. Now, on day-to-day imaging, we're a lot more interested in the omental bursa than we are in the lesser omentum, because any patient with cancer can have metastases in their omental bursa, but very few patients are we looking for fluid collections on. Now, again, that anatomy we've already kind of looked at in this picture where we retracted the liver to look at the gastrohepatic recess and the right anterior subhepatic space. The lesser omentum is comprised of the larger gastrohepatic ligament and the smaller hepatoduodenal ligament. Again, from a fluid collection perspective, we're far more interested in the gastrohepatic ligament. But in day-to-day imaging, we're far more interested in the hepatoduodenal ligament because it has the portal triad in it. We're interested in the portal triad in every patient. We're only interested in the gastrohepatic ligament in a minority of patients. Now, the gastrohepatic ligament inserts into the fissure of the ligamentum venosum. The reason you see the fissure of the ligamentum venosum as that nice bright white line is because of the fat in the gastrohepatic ligament that inserts into it. So I'd have been happier if they'd have called that the fissure of the gastrohepatic ligament. There again is our transverse mesocolon running from the pancreas to the transverse colon. So indeed, the lesser peritoneal cavity is a supramesocolic space. There is our omental bursa. We can see that it is fused, so we don't think about that in terms of fluid collection accumulation. Now, where one sees the portal vein come down and touch the anterior surface of the inferior vena cava marks the position of the Winslow foramen. So, if you were to take your finger and lift up the portal vein off of the cava, your finger would be in the Winslow foramen. Now, it is possible for fluid to pass through the Winslow foramen, but it usually doesn't. So we tend to have either lesser peritoneal or greater peritoneal collections, particularly pathologic ones, not so much ascites. Now, there are lumpers and splitters in the lesser peritoneal cavity. Lucky for you, I'm a lumper, and I'm really only interested in two spaces, the splenic recess and the superior recess. These are seen better in an axial plane. The splenic recess does run all the way over to the spleen, but in fact it largely lies between the posterior wall of the stomach and the body of the pancreas. The superior recess surrounds the caudate lobe of the liver. Now, here we see the gastrohepatic ligament. That bright fat there is in the gastrohepatic ligament. So this fluid is definitely in the splenic recess of the lesser sac. Here's our gastrohepatic ligament. That fluid's in the splenic recess of the lesser sac. Here's our falciform ligament. So that little bit of fluid is in the left subhepatic space. That little bit of fluid is in the right anterior subhepatic space. That little bit of fluid is in the splenic recess of the lesser sac. So I can tell you practically CC for CC where that fluid is. So again, there's a lot of fat usually in the gastrohepatic ligament. You can see it making a claw sign here with the stomach. So this fluid is definitely in the splenic recess of the lesser sac. Here you see that fluid in the stomach, the fat in the gastrohepatic ligament, and the fluid in the lesser peritoneal cavity. Now, here you see the fissure ligamentum venosum, or the gastrohepatic ligament, and our caudate lobe. So this fluid here is in the splenic recess of the lesser sac. And that little dark band drib of fluid, probably less than 0.2 of a cc of fluid, is in the left subhepatic space. So again, you don't want to get into a contest with ultrasound for finding little dribs and drabs of fluid. Here we see the fissure for the ligamentum venosum, the gastrohepatic ligament. Once the beam enters the caudate lobe, it must also leave the caudate lobe and enter the superior recess of the lesser sac. So the fact that there's less than 2 cc's of fluid in the superior recess of the lesser sac, irrelevant. We're going to find it. Now, when it comes to the splenic recess, we cannot be sure unless we've actually seen the body of the pancreas. So here are some ascites in the splenic recess. Here a pseudocyst in the splenic recess. Now, to be perfectly honest, I don't really find it that challenging to find lesser peritoneal collections. Here we see quite a large one. More often, people have problems saying, where is that peritoneal collection? But it's actually quite straightforward. Here's the spleen, There's only 2 spaces over here, the subphrenic space and the splenic recess. If the fluid collection is medial to the spleen, splenic recess, lesser sac. If it's lateral to the spleen, subphrenic space. Here again, the patient has a nasogastric tube in the stomach causing that shadow. We can see that the fluid is in the splenic recess of the lesser sac. Fissure ligamentum venosum, the gastrohepatic ligament, caudate lobe. 1 cc of fluid also in the superior recess of the lesser sac. Here's a patient with an abscess in the splenic recess of the lesser sac. Definitely because it's medial to the spleen and not lateral to the spleen. Here's a patient that didn't have a spleen and developed a large collection. And again, a little more challenging because of gas in the stomach, but you can see that the fluid is in the splenic recess of the lesser sac. Now, while I can't guarantee that I'm going to see the splenic recess of the lesser sac with clarity in every patient, I can always sneak a peek. Because if you can see the splenic vein, then the beam actually enters the splenic recess of the lesser sac before it can encounter the stomach. The beam is coming this way. So it actually enters the lesser sac before it can encounter gas in the stomach. So it doesn't matter whether I see the tail of the pancreas or the splenic vein, I will always be able to sneak a peek in the splenic recess of the lesser sac. So, have I seen the left subphrenic space? The answer is yes. If I've seen the left lobe of the liver and the spleen. Have I seen the gastrohepatic recess? The answer is yes. If I've seen the lateral segment of the left lobe of the liver. Have I seen the superior recess of the lesser sac? The answer is yes. If I've seen the caudate lobe. How often do I see those? All the time. Now, I can't be sure of the splenic recess, although I can always sneak a peek. Now we're going to move to the inframesocolic spaces, and I can hear the thoughts in your mind, well, Dr. Philly, up here you had the liver and the spleen, so you were kind of lucky. But now you're down there where all the bowel is. So how are you going to do in the inframesocolic spaces? Well, there are 8 inframesocolic spaces. 4 are above the pelvic brim and 4 are in the pelvis. They are unequally divided right from left by the root of the mesentery. So the root of the small bowel mesentery begins in the midline, but slopes heavily to the right side, meaning showing us that the right-sided inframesocolic spaces are smaller than the left. Again, the spaces are analogous. We have the right and left pericolic gutters. This is the position of the ascending and the descending colon. The pericolic gutters lying between the body wall and the colon. The infracolic spaces lie to the right and left of the root of the mesentery and inside of the ascending and descending colon. Again, the left infracolic space, much larger than the right infracolic space. There is our pelvic brim. There are 4 spaces in the pelvis, the right and left paravesical space, the supravesical space, and the rectovesical fossa in males and the cul-de-sac in females. So, We see the bladder in the position of the supravesical space, the position of the rectovesical fossa posterior to the bladder and in front of the rectum. And then we also have the right and left paravesical spaces. I'll point out momentarily. Here in this female who's undergoing peritoneal dialysis, we can see that the peritoneal dialysate is in the supravesical space and the cul-de-sac. But the important thing is, the peritoneal dialysate is a sufficiently powerful mass to completely displace the bowel out of the supravesical space. And if peritoneal dialysate can displace the bowel away, so can an abscess, which is a much more powerful mass in terms of space occupying. Here, in these, we see the paravesical spaces lateral to the bladder wall. Now, immediately upon exiting the bladder wall, the beam enters the supravesical space, the paravesical spaces, and the rectovesical fossa. You have to be reasonably impressed by that bowel gas. Lots of bowel gas. But it can't stop me from seeing the fluid in the rectovesical fossa or the supravesical space. Now, we've talked before about the fact that fluid can flow between these particular spaces, and this is particularly true on the right side, where fluid can go all the way from the cul-de-sac to the right subphrenic space. But it's not true on the left side of the abdomen, where we have the phrenicocholic ligament, which serves, it comes from the posterior body wall. It's like a dam. And the fluid has to flow over the dam in order to get from one place to the other. So remember, we talked about inordinate fluid collections in the left subphrenic space. Here you see the phrenicocholic ligament dividing the fluid in the left subphrenic space from the fluid in the pericholic gutter. Here you see again the phrenicocholic ligament. Here there's a more even distribution of fluid between the pericholic gutter and the left subphrenic space. We see this ligament nicely because, like all of these ligaments, it has fat in it. So it's a nice bright white ligament. Now you actually see the phrenicocholic ligament more often than you think. You don't need to have ascites to see the phrenicocholic ligament. It's like a little hammock for the inferior tip of the spleen. So you can see this little hammock for the spleen tip. That means that fluid is in the pericholic gutter on the left side. That little bit of fluid there is in the subphrenic space. So here we got 5 cc's of fluid, but we can see how many cc's are in the subphrenic space and how many cc's are in the left pericholic gutter. Now, in bowel-containing areas, can we be sure we have seen the pericholic gutters? And the answer is yes, if we are smart enough to place the transducer in the mid-axillary line and aim dead center into the middle of the patient, because then the beam must pass through the pericholic gutter before it can possibly encounter gas in the bowel. So if we place the transducer in the mid-axillary line, aim at the middle of the patient, the beam passes through the fluid in the pericholic gutter before it can encounter gas in the bowel. Now, I have saved this picture for more than 25 years because you gotta be impressed by that bowel gas. I mean, wow. But it can't stop me from finding this little bit of fluid in the pericholic gutter. So, here's a patient with a colon that is distended with bowel gas, but it can't stop me from finding this fluid in the pericholic gutter. Gas in the colon cannot stop me. Here's a patient with an abscess in the right pericholic gutter, and again, you have to be impressed with that bowel gas. I mean, that is big-time bowel gas, but I'm going to find the abscess in the pericholic gutter. Here in the left pericholic gutter, I don't care about the bowel gas. I'm going to find these 2 abscesses in the pericholic gutter. And again, if that one doesn't drain through that abscess, this abscess won't be drained. So, as far as the supravesical space, rectovesical fossa, and right and left paravesical space, as soon as the beam exits the bladder wall, it will enter those spaces. So if I'm simply wise enough to make sure there's a little bit of urine in the bladder, then I know for certain I've interrogated all of those spaces. So this little bit of fluid in the supravesical space and this little bit of fluid in the cul-de-sac, in this case a hemoperitoneum, are visible. Indeed, I don't have to tell you. Every day you make a decision about whether you are or you are not going to call fluid that you find in the cul-de-sac of a female patient. No, we would all call that a normal amount of fluid. It's not pathologic. So, volume is not the issue. The issue is beam direction and interrogating spaces. So, here, as soon as the beam exits the bladder, it enters this abscess in the supravesical space. As soon as it exits the posterior wall of the bladder, it enters that abscess in the cul-de-sac. Okay. In the infracolic spaces, clearly I have a problem. So, have I seen the pericolic gutters? The answer is yes. If I've placed a transducer in the mid-axillary line, aim toward the middle of the patient. Have I seen the supravesical space, the rectovesical fossa or cul-de-sac, and the paravesical space? The answer is yes, if I've seen the urinary bladder. The infracolic spaces, I can't be sure. However, I'm still going to find most of the abscesses in the infracolic spaces. Why is that? Because the infracolic spaces communicate freely with the supravesical space. So if I have some urine in the bladder, I have a fighting chance of finding this abscess, even though that abscess is not in the supravesical space. It's actually in the right infracolic space. An abscess in the infracolic space may, in and of itself, be large enough to push the bowel out of the way. Also, although the abscess is often surrounded by bowel gas, it frequently causes some inflammation to the bowel, and therefore, the gas passes through that segment rather rapidly, and it accumulates in other places. But through that segment, I can often look through and find the abscess. And as you know, we look for appendicitis, and we've learned that we can compress a lot of bowel gas out of the way by simple compression. And I don't have to tell you, we're reasonably good at finding appendicitis, but we're actually better at finding periappendiceal abscesses than we are at finding appendicitis. And as I once said to you a little while ago in the lecture, an abscess wants to do one of two things. It either wants to find its way to a body wall and rupture out, or kill you. So the abscess is actually trying to find its way to the abdominal wall, giving me a fighting chance of finding it. When we think about the kinds of things that cause abscesses, number one on the list, postoperative complication. What are the common surgeries? Cholecystectomy. Where do you get the abscess? Right anterior subhepatic space, right posterior subhepatic space, right pericolic gutter. Now, I can interrogate all of those spaces. If they are negative, I don't care if the patient has a ton of bowel gas. There's absolutely no chance the patient got their abscess in the left infracolic space. So I get called from the intensive care unit. Dr. Philly, we can't send this patient for a CT scan. He just dropped his blood pressure, is running a fever, he's 10 days post-op cholecystectomy. I go up, I examine, those three spaces are clean. I don't care if he has gas overlying the left infracolic space. My study is negative. I will be right. This patient just has a hematoma. He didn't actually have an abscess. But again, I'm going to find it. This patient did have an abscess, but gas in the duodenum is not going to stop me from finding it. This patient we looked at before perforated his gallbladder. This bowel gas can't stop me from finding that abscess. Post-hysterectomy, supravesical space, and cul-de-sac. I can see those spaces all the time. Also true for appendectomy, right pericolic gutter, supravesical space, occasionally the Morrison pouch. Also true for splenectomy, partial hepatectomy, colectomy. Doesn't matter. Now, these spaces are searchable in virtually every patient. The right and left subphrenic space, the right and left subhepatic space, the spaces, the superior recess of the lesser sac, the right and left paracolic gutters, supravesical space, right and left paravesical spaces, rectovesical fossa, and cul-de-sac. These are only searchable in some patients. Splenic recess of the lesser sac. So when do I have to be cautious? Beware of pancreatitis. That's who gets abscesses there. I can't always search the right and left infracolic spaces. Where do I have to be aware there? Patients with Crohn's disease, diverticulitis, and small bowel surgery. But otherwise, even on a search and destroy mission, I think the patient has an abscess, don't have a clue where it is, don't know why. I start ticking off spaces. Right subphrenic, right anterior, right posterior subhepatic, left subphrenic, gastrohepatic recess, superior recess of the lesser sac, take a peek into the splenic recess of the lesser sac. Place the transducer here, check to make sure the paracolic gutters are clean. Look through the bladder, supravesical space, rectovesical fossa, paravesical spaces. Then I make my best effort at the right and left infracolic space. If the study is negative, I won't be right every time, but I'll be right almost every time.